so plenty to discuss, so we'll maybe keep that for our panel discussion. So thank you to all our speakers so far for the in-depth review of the methods of MRD testing. So I'm delighted to introduce next Dr. Karthik Ramasamy, so consultant hematologist and associate professor, Oxford University Hospital, and director of Oxford Myeloma Translational Research Centre. So Karthik is going to help pull all this together and help us convince us or otherwise whether the UK is in fact ready for MRD testing into routine practice.
Thanks, Jenny. I'll really try my best to pull all of us together. Let's see how we go. So this is how I'm going to operate over the next 20 minutes. I'm going to start with a case study, and then I'm going to do a frequently asked questions about MRD that typically is discussed in meetings. And I've termed what are MRD landmarks, which is why we're talking about MRD today. And then I'm going to run through some clinical trials which talk about or refer to where we could be using MRD in current practice and potentially in future practice. So before pulling this talk together, I did a straw poll, ring up a few people, and I asked them, I would do MRD tests in myeloma patient if, can you complete the sentence? So different folks said different things, and first person said, I'm able to change treatment based on the results. I'd be doing an MRD test. If I know that my patient is functionally cured, then I will do an MRD test. And if I'm able to prognosticate treatment outcomes in the medium term, then I will do an MRD test. And then I'm able to access these tests routinely in clinical practice, like the question earlier, then I'll be doing an MRD test. I think the flavor that I'm getting is I think people are after different pieces of information, and constantly I think that is also a challenge that we have to recognize when it comes to routine practice, because our needs for the patient in front of us are different, and then obviously there are some logistical challenges. So let me start out with the case study. This is a 62-year-old lady who I diagnosed back in February 2017 and has a past medical history of IBD and history of DVT in the past, and presented very classically with bone pain and fatigue, two dominant features during a diagnosis of myeloma, IgG kappa myeloma with a hemoglobin of 92 grams per liter, fracture in L4, and hyperdiploidy on myeloma fish, ISS stage 2. This patient got treatment with VRD ×4 to very good partial response, and blepharitis needing doxycycline because of bortezomib, grade 1 peripheral neuropathy, and IBD got worse symptomatically during this treatment. As we would take our patient through transplant with high-dose melphalan, and a bone marrow confirmed CR, and PET-CT was negative. The patient had 2 further cycles of VRD consolidation, further issues with IBD, and the patient started lenalidomide maintenance therapy, and as you can see, about close to 14, 15 months worth of maintenance, there are some issues. So this has not been formally built in as a poll, so I'm now looking for show of hands. So you're looking after this patient in your clinic, and you've got these choices as the patient's kind of pushing to stop treatment potentially. So what would you do? So the number of people you would use MRD to guide treatment decision, that's choice 1. Would you choose a low-dose lenalidomide maintenance? Would you use an alternative drug for maintenance? I mean, there are some MSMART guidelines around maintenance with other drugs. And then would you do a treatment-free monitoring? So how many of you would choose option number 1, meaning use an MRD test to guide a treatment decision here? Hands up. Wow, okay, only 4, yeah. How many of you are going to do low-dose lenalidomide maintenance? Okay, about 10, 15, yeah. Alternative drugs for maintenance? 1 or 2 takers, yeah. Treatment-free monitoring? 1, okay. So this patient goes on low-dose lenalidomide maintenance as it is right now. Okay, so let's go through the MRD FAQs. So Constantly we discuss in the myeloma meetings about MRD. So these are the questions that are constantly asked, and I've tried my best to put some answers to it. So question number one, should MRD be the new CR? Potentially, there is going to be a revision of the response criteria, and new definitions of CR MRD positive and CR MRD negative are emerging. Roger already showed the FDA approval slide, and that is technically called CR MRD negative. So you need to get to CR, and then you have to do the bone marrow, and then you've got to get your MRD negativity at 10 power minus 5. That's what the definition is. So MRD doesn't stay alone. Second is MRD testing for prognostication. Yes, a lot of data already shown, clearly shows that MRD negativity improves clinical outcomes. What is the right threshold for MRD testing? You've already seen a few thresholds flashed up in slides. The IMWG guidance, as I will show later, is 10 power minus 5 is the threshold you should meet. What MRD test should I use? It is actually not specified by IMWG. Use a test that can get you to that threshold, is exactly what they say. When should I test for MRD? You should have suspected CR, and then potentially yearly, provided the patient remains in CR biochemically, is technically how you would repeat MRD testing. Is one-time MRD testing enough for my patients? It is still helpful to prognosticate, but clearly sustained MRD negativity is where you continue to divide up the good players versus the bad players. And does early MRD negativity equate to improved clinical outcomes? We actually need more data. I'm going to show you the MIDAS trial data and some other trials that are happening in this space. And the other two questions, as you can see here, need more data. And can I use MRD results to make clinical decisions? We want to get there. The trials are being done, RADAR, MIDAS, PERSEUS, and MASTER, and I'm going to take you through those slides as to what they are. So I see three important landmarks in multiple myeloma MRD testing. The first landmark is MRD getting into the IMWG guidance was the first landmark, and they defined a threshold of 10 power minus 5 is the recommended minimum sensitivity that you should look for. So that was a key landmark for us. And this was a while back, and as I said, this will be refined further in the new paper that will come through either later this year or early next year. The second landmark that was already shared by Roger is after many, many years of many groups pulling together, presenting data to FDA. EMA has not approved it yet, it's just FDA. What has been accepted in the recent ODAC meeting is that MRD testing is an intermediate endpoint. It's not that trials close at that point. You've got to follow them out to PFS, but you could get a conditional approval early on for drugs. And obviously that's a major landmark in multiple myeloma. Essentially means you get access to drugs earlier for patients. The third big landmark is the fact that there are a lot of clinical trials on this slide. On the left-hand side is triplets in newly diagnosed patients. On the right-hand side, you've got loads of trials with quadruplets in the control arm. And you can see MRD testing done in this patient population. We're hitting rates of upwards of 50%. So we should be thinking about doing MRD tests because that's what these patients are getting. Almost 50 to 70% of patients getting to MRD negativity. So the final landmark is the fact that we are going to be potentially using quadruplet therapy for newly diagnosed myeloma patients across the whole spectrum, and it's potentially going to happen this year for patients. So we should be thinking about doing MRD testing. So the final piece is around role of MRD in UK practice. So there are three areas that I'm thinking about. One is prognostication. Second is around duration of therapy, and third is around deferring ASCT. So what do I see as the current implications to practice? The first, I would start with the Cassiopeia data. We use Cassiopeia treatment for newly diagnosed transplant-eligible myeloma patients outside of clinical trials, and you can see those Kaplan-Meier curves showing progression-free survival And as you know, the randomization post-DVTD was to data to monthly maintenance versus no maintenance. So majority of patients who are in the top curve who got to MRD negative CR, and you can see the shape of the curve, majority of them did not have any maintenance therapy, and that's the shape of the curve in this patient population. So you've got to wonder, is there an opportunity to limit duration of therapy? Should patients turn up month on month having treatment, when you know that their disease is extremely well controlled? The second is about limited duration. Um, for, for many of you, you would know that IFM 2009, there was a mandate to give limited duration lenalidomide for 1 year maintenance. Again, this slide was shared by Roger earlier, and the point I'm making here is look at the patients on the red curves, which is MRD negative standard risk who are having 1 year lenalidomide maintenance, and look at the proportion of patients who are progression-free. Again, limited duration lenalidomide maintenance. I understand lenalidomide maintenance is current standard of care given continuously, but this is the shape of the curve in an MRD negative patient who has fixed duration 1 year lenalidomide maintenance. The question we have to ask ourselves is, do all patients need to get 6-7 years of kind of maintenance therapy is what it is. So moving from transplant eligible to transplant ineligible, we all know that the IMROS trial has been recently presented, and ESA VRD is currently going through the NICE process, and there's a meeting coming up in the next couple of months. So it's timely to kind of look at the data that's summarized in this slide. So it was 3:2 randomization to ESA RVD versus RVD. So bortezomib gets dropped after roughly the first kind of 6 months of therapy, and then patients continue on ESA RD. And you can see the significant improvement in progression-free survival for ESA RVD. The other thing that is quite striking as you would compare the overall response rate and even like complete response and stringent complete response, there's minimal amount of differences if you just look at it from a response rate perspective. But what's striking when you come and look at the deeper end of responses, the fact that you have more patients who are MRD negative on the ESA RVD arm in comparison to the RVD arm. And when you keep doing these MRD testing on a yearly basis, what you find is the proportion of patients who are staying MRD negative for over 24 months significantly higher in the ESA RVD arm, and about a quarter of patients being sustained MRD negative for more than 36 months. So clearly these are potentially treatments that we're going to be using for patients in routine clinical care. And this is again the shape of the curve for the ESA RVD MRD negative patients. And we're talking about patients who are with a median age of 72, 73. And look at the shape of the curves in these patients. And these are MRD negative patients. So the question really is, do we want to share that information to our patients when they are in ongoing treatment on ESA RVD being kind of MRD negative? So those are the things I think are implications for current practice. So what are the implications for future practice? There are potentially 3 important implications. One is about opportunity to modify maintenance therapy, and this is the Perseus trial that was reported by the EMN group, which looked at data VRD versus VRD, and in the data VRD, DR maintenance was given for 24 months, and you could discontinue daratumumab after 24 months if you had sustained MRD negativity, so the opportunity to modify maintenance therapy. And these are the MRD negative rates at 10 power minus 5, 10 power minus 6, but on the right-hand side here, you see the sustained MRD negativity rates. And as you can see, a significant proportion of patients, over 50% of patients, have discontinued daratumumab after 2 years of maintenance therapy. It is not approved yet at this point in time, but potentially could be approved, and we would be using MRD tests to limit duration of doublet therapy in this patient population. So an implication for future practice. Second is around deferred transplants. There are two trials, well, potentially three trials that are currently ongoing, which are looking at kind of a deferred transplant. The first is the MIDAS trial. As you can see, you do an MRD test after 6 cycles, and if you're MRD neg, you're considered low risk, and you're randomized between transplant versus just consolidation on the top section, as you can see here, and getting a fixed duration lenalidomide maintenance. And if you're high risk, then the question is whether you do single transplant or you do double transplant is what's being asked. So potentially, if this shows no significant difference in progression-free survival, then you would do an MRD test after your induction and then potentially defer transplant for these patients. But we don't have the data yet. I will share with you the MRD negative rate. I want to just point out again, University of Miami are running a similar trial called ADVANCE, again looking at de-escalating and not doing autologous stem cell transplant in these patients. This is the data that was presented by Aurore recently at an IMS meeting. So the MRD neg rate, as you can see, is about 63% of patients. Significant. 2 in 3 patients are getting to MRD negativity after induction treatment with a quadruplet. Pretty significant, and will have significant implication for future practice if the transplant versus no transplant showed similar PFS. Again, MASTER-2 in Alabama, run by Luciana Costa's trial, is also looking at, in an MRD negative patient population, no transplant and just consolidation as an option, and again a fixed duration maintenance. So deferred transplant is now being looked at in many of these trials, and these results will come through over the next 2 to 3 years and will have a significant implication for our upfront transplant practice in this patient population. So the final piece to conclude with is, obviously I would make a plug for RADAR, which we run in the UK, and we are looking at, based on MRD, a de-escalation for MRD negative patients to monotherapy with isatuximab, and a randomized way of looking at whether we could have fixed duration maintenance versus continuous is something that we're looking at. The second important question, I don't think is necessarily getting that much press, is the fact that in your MRD positive patient, currently, if we do a test, post-DVT deconsolidation, we give everybody lenalidomide. If you're MRD positive, Roger Owen and colleagues showed that about 10 to 15% of patients can convert to MRD negativity. And the question really is, by giving consolidation, are you transferring more patients to MRD negativity? And therefore, is that why you're improving your progression-free survival? I'm not aware of many trials asking this question about consolidation versus direct maintenance approach, and RADAR will provide that evidence, because I am aware that many centers do not necessarily do consolidation post-transplant if patients are in CR, and that could potentially change if you get results from this clearly showing that you drive more MRD negativity. And DRAMATIC is a US study, a SWOG trial, which again is looking at limited duration maintenance based on MRD testing here. So, having presented all this clinical data, I'm going to come back to the same question I asked you at the beginning. So again, going back to this patient who has had about 15 months worth of lenalidomide maintenance and is in CR and PET negative, hyperdiploidy disease, standard risk disease, would you still give low-dose lenalidomide maintenance continuation, or would any of you, apart from those 3 folks who wanted to do that MRD test, do an MRD test and consider having a discussion with the patient to guide treatment decision? Option 1. Oh, good. Thank you, Neil. There are some friends in the room. Yeah. Very good. Okay, so I'm going to finish up and look forward to a great discussion. Thank you.